Welcome to the Healing Pain Podcast with Dr. Joe Tatta. Each week, we interview top experts in physical therapy, pain science, and integrative pain care. You'll learn the most up-to-date information for treating and reversing persistent pain. This podcast is for educational purposes only and not intended to be used as personalized medical advice. And now, here's your host, Dr. Joe Tatta.
Hey there, friends and colleagues. Welcome to another episode of the Healing Pain Podcast. I'm your host, Dr. Joe Tatta. This week, we're diving deeper into the utility of pain neuroscience education and investigating if it's enough to help people overcome pain when used as a single treatment modality, or should it be folded into a more comprehensive multimodal pain treatment program. My guest this week is Rilind Shala, who is a young scientist and a physical therapist from Kosovo. He conducts research with the prestigious Body and Mind Group and has earned many international accolades for his work in both physical therapy as well as pain management. On today's episode, we cover how pain neuroscience education is used in clinical practice, the clinical impact of pain neuroscience education on outcomes such as kinesiophobia and pain catastrophizing, and the essential tools and techniques you can combine with pain neuroscience education to improve its impact on quality of life. And if you enjoyed this week's episode, make sure to take a screenshot with your smartphone, upload it to Instagram, and then tag me. My handle is at drjoetatta.com. That's at drjoetatta.com, and I'll be sure to tag you back. Okay, let's get ready and let's begin and let's learn about pain neuroscience education. Hey there, Rilind. Welcome to the Healing Pain Podcast. It's great to have you here.
Hello, Joe. Thanks for having me.
I'm excited to chat with you. I know, lots of the work we do here on the podcast is to reach out to both experienced researchers in the field of physical therapy and pain science. And I'm always on the lookout for young scientists like yourself who are doing interesting work and have plans to do interesting work in their PhD. I think a good place to start, we're going to talk about a paper that you published just recently. I'll mention the paper now. So the paper is called, "Can We Just Talk Our Patients Out of Pain? Should Pain Neuroscience Education Be Our Only Tool?" And that was printed in the Journal of Manual and Manipulative Physical Therapy, Journal of Manual and Manipulative Therapy. We're going to talk about the paper, but first I want you to introduce yourself and just tell people who you are, where you're from, and kind of the direction that your career is going with regard to being an early researcher.
Yep. Thanks for having me, Joe, first of all. I love your podcast and I listen to all of your episodes, so to say, and it's a nice invitation. I am Rilind Shala, first of all. My name is a little bit difficult to pronounce because I come from Kosovo. It's in Europe, near Albania, or also near Croatia in Balkans, so to say. And yes, I'm an early career researcher, and that's actually my third paper. More to be published, but that's only my third paper, and it's published in the Journal of Manual and Manipulative Therapy. I'm a physical therapist looking to go into a PhD program. But that's just my third paper, and I'm more, so to say, focused on pain neuroscience education, also clinical sports medicine, and also low back pain research. So that's where my research interests are focused in.
Great. So you mentioned this is your third paper. So this paper is specifically about pain neuroscience education. What were your first two papers about?
The first two papers were about NEOA, and the first paper was actually about NEOA, and it was more focused on the biopsychosocial approach and treating NEOA in the biopsychosocial way. The second paper was also about diagnosing low back pain, and it was also in a more biopsychosocial and neuroscientific approach. So we can look for the, so to say, source about low back pain and treat it in the more modern pain or the more modern explained pain source.
So two papers kind of steeped in the biopsychosocial model of pain, moving toward pain neuroscience education. Of course, this paper is about pain neuroscience education. Why was it important for you to write this paper? Why is it important for us to read this paper?
For me, as an early career researcher, before I published those papers, I always read about pain neuroscience education and also about the biopsychosocial approach. For example, when we read the latest literature right now, we always see that the biopsychosocial approach is the focus of treatment, because if we take, for example, a patient, and this patient will be treated in the biomedical approach, we treat the patient in a biopsychosocial approach, it will be all, so to say, a different world for the patient, because the pain neuroscience education teaches us that we can treat the patient. Also the bio, for example, if he has a low back pain injury or he has a shoulder strain or something, Also, we treat the bio, we also treat the psychosocial factors. And this was really an important topic for me because all the literature right now is also focusing on the psycho factors and also the social factors about the pain.
Can you explain pain neuroscience education in your own words and why it's important?
For me, pain neuroscience education is a tool, and this is a tool that teaches. For example, I have many patients that here in Kosovo, for example, the biomedical approach is widespread. Many people use the biomedical approach. And I have had many patients that when we treated the patients the biopsychosocial approach, it was really better for them. And when we did neuroscience education for them, for example, with pain neuroscience education, I can understand it a little bit better when we can explain it in terms like explaining pain or pain neurophysiology or pain neurobiology for the patient, so that the patient doesn't think that pain is the start and pain is the end of the story. For example, a patient has pain, but it's not the end of the story. We can retrain the nervous system to learn pain and to deal with pain. And that's really important for the patient, because if the patient thinks that, yes, I have pain, I have nothing to do about, I am lost, I can't do anything about this pain, then the patient is practically lost and has also lost the face to health professionals and also to himself.
So pain neuroscience education has been around for a while. Before that, kind of the predecessor was Explain Pain. So both are useful and evidence-based interventions, similar, very similar. Why has P&E started to shift in the world of physical therapy?
That was also a part of the paper, because when I started to write the paper with Professor Laura Marmostian, with Natalia Russell and other authors, we always thought that pain neuroscience education has done a shift in the treatment procedures that we have done in physical therapy, also chiropractic, orthopedic, sports medicine, and so on. For example, when we treated the patients with a biopsychosocial, again, or with pain, or teaching people about pain, their behavior shifted, because as we mentioned in the paper, when we use the pain neuroscience education approach with the patient, we also decrease their pain beliefs, because many patients, especially here, again, telling here about the stories that we see patients every day here, when we treat patients with this approach, their pain beliefs decrease and their fear avoidance behaviors decrease as well.
Yeah, I like the way you frame that, Rilind, because you said behavior shifted. So often when people talk about pain neuroscience education, or really any other cognitive intervention, they're so focused on thoughts and beliefs changing, which we'll talk about. Sometimes that happens, sometimes that does not happen. Oftentimes it doesn't happen fully, but what we're really looking for is a change in behavior, right? That's really the point of all these cognitive and behavioral interventions, is that there should be a change in behavior.
That was also the point of this paper. For example, I personally think that if we use pain neuroscience education, we can't do as much with the patient in the sense of the pain decreases or so on. But if you can use pain neuroscience education as a tool for the patient to change the behaviors, change the beliefs, decrease the pain catastrophizing, then the quality of life or the quality of the treatment that we give will be so much better. For example, if we sit down with the patient is here, we sit down and we talk every day about pain, the signals, nervous system, proceeding of pain, and others, we can't do as much with the patient. I've got many patients that, for example, I discuss with them pain, and they say, okay, but I'm not so much interested in pain. I have to know what I have to do to be better. But if we can teach pain in a more simplistic way, that the patient will learn and listen from us, then the patient will change his behavior, and then will change also his life, so to say.
Yeah, really, really well said. I appreciate that, Rilind. So as the title of your paper says, can we talk our patients out of pain? So I'd be remiss not to ask you that question. Can we talk our patients out of pain, as your article so appropriately asks?
Short answer, we can't. But the positive answer we can get from here is that when we use the pain neuroscience education approach, we can do many, many other things. If we just, like I said, if we just sit down with the patient and talk every day about pain, we can't do anything with the patient. But if we discuss about everything that the pain influences to the patient, for example, I have many patients that are stressed, demotivated, have high levels of anxiety, high levels of pain catastrophizing. And if we describe pain neuroscience, or if we educate the patient that pain is not the end of the story, or if we educate the patient that if you have pain, for example, if the patient has chronic or persistent pain, if the patient has pain, it doesn't mean that it's all over. It doesn't mean that the tissues are over, because we often, for example, when we educate the patient upon pain, often we use the metaphor that pain is not or is not connected with tissue damage. For example, if the patient has chronic low back pain, most of the patients go get a scan, and when they get a scan, they come to me and say, "Hey, Rilind, I have seen the scan. The doctor said to me that I have a protrused disc, or I have disc bulge, and now I'm screwed. I have to go to surgery and so on." But we describe that, for example, he has 6 months, 7 months of chronic pain, and the pain has more to do with the overprotective nervous system than it has to do with the tissue damage that the patient has.
Right. So we cannot talk our patients out of pain.
Certainly not.
Right. But there are aspects of explain pain, P&E that are helpful, that are useful. What are the most important outcomes that we see when we use this? And I just want to return to that. So when we can't talk our patients out of pain, it really just points us to the fact that this is an important feature of treatment planning, but it shouldn't be the sole treatment. So we can't just sit someone down for 8 sessions, let's say, or 4 sessions and just talk to them about pain, so to speak.
Yeah, like any treatment used as a standalone treatment won't be effective. We can have a patient that has chronic low back pain and we can use acupuncture, for example, every day with them, but it won't be effective. That's like, for example, if we have a patient, and I've got many people that read the paper and sent me an email and said, have you ever talked the patient out of pain? For example, have you sit with a patient and talk him out of pain? But let's know how it works. If you use pain neuroscience education or any other treatment as a standalone, it won't probably work.
Is pain neuroscience education necessary for all pain conditions?
This depends. For example, if we have chronic pain, persistent pain, or also nociplastic pain, where there is an alternation in the central nervous system, and we have also central sensitization or also peripheral sensitization, then it's really good to use pain neuroscience education, because we can teach the patient that pain is just a protectometer, so to say. So pain protects us. If we don't have pain, then we will probably be dead. So we can teach the patient, especially in conditions where the patient has allodynia, has primary hyperalgesia, or also secondary hyperalgesia. We can educate the patient that pain is not everything. We can, so to say, like the speaking that was about Lorimer mostly, pain is about everything that we teach the patient. And when it comes to pain, everything matters. So we can explain pain in a way that the patient understands, that he can move, he can run, he can do all the kinds of physical activities that you want, and he can live again.
Great. And you mentioned central sensitization, which everyone following this podcast is pretty well versed on if they've been following this over the course of the last few years. But you mentioned nociplastic pain, which is a relatively new definition that came out of the International Association for the Study of Pain. It kind of replaced central sensitization in a certain way. Can you explain what nociplastic pain is, kind of in a little bit more layman's terms?
Yeah, for example, if the patient has a condition, and in this condition he has altered central processing mechanism. For example, if the pain that is processing on the central nervous system is altered, then the patient will have, so to say, nociplastic pain. The good news is that this pain, like nociplastic, neuropathic, or also normal pain, all will be influenced by exercise. If we move, if we run, if we do physical activity, all this will be, so to say, better, because if the patient can move, can exercise, and can live his life like he wants, then all the central pain mechanisms will be altered. And we also know that in the body, we also have a mechanism that produces opioids. If we do, for example, manual therapy, if the patient can move, then the opioid will be produced and the patient or the pain will be decreased.
Right. So you just mentioned central mechanisms, and then in some way you mentioned a peripheral treatment to impact them. So
yeah, we can have indirect mechanism or indirect influence to central pain.
Right. Or direct influence. So a direct influence might be something like pain neuroscience education or acceptance and commitment therapy, let's say, that where it has an impact on pain, fear avoidance, pain catastrophizing, pain acceptance. Those are all more central mediated mechanisms.
Yeah, because they are also interconnected. For example, if we use pain neuroscience education, we can also use other treatments. This has been by Elrin Lu, this has been called PNA plus, because this plus is added, for example, movement, exercise, pain behavior therapies, and also acceptance and commitment therapies. So we can all use these kind of mechanisms or tools we have to impact the patient and to impact his pain and his life.
Right. So we have many tools to impact nociplastic pain.
Yep, many tools if we can use them. For example, if we use pain neuroscience education to teach the patient that you can move, you can exercise, you can do all the kinds of physical activities, then we have reached our goal to treat the patient. If we use just pain neuroscience education to teach the patient that the mechanism of pain is this, the neurophysiology of pain is this, and neurobiology of pain is this, then we can do much for this patient. But if we in some way influence the life of the patient, for example, we educate the patient that he can move, there is no problem that he has knee OA, it's no problem that he has chronic low back pain, then the patient can start to move again, is not fearful, the fear avoidance beliefs will change, he will start to flex. If we are talking about chronic low back pain, he will start to move and also run again. So we have improved the life of the patient.
Yeah, and I spoke with Adrian Lowe about PNE Plus a couple of weeks ago, and that's why I wanted to connect with you, because I think the paper you published adds to that aspect and adds to that literature where pain neuroscience or explain pain absolutely has its place and every practitioner should be using it, but we need to plus or tag something on to that treatment. Of course, as physical therapists, exercise, manual therapy is high on the list. But it's interesting, as I read through your paper, there's one line somewhere that actually states that P&E or explain pain helps people move better and actually teaches them to move even if pain is present. So that aspect of even if pain is present, to me, because I've trained a lot in mindful and acceptance-based approaches, really starts to point toward there's probably a little bit, I know this hasn't been studied well or at all, but there's probably a little bit of pain acceptance happening even within a P&E aspect. But if you tag on, let's say, something like mindfulness or acceptance and commitment therapy, it may be more effective with regard to that pain acceptance aspect.
Yep, that's what also we think about pain neuroscience education, because if we teach the patient in the right way, then most of the patients will not be fearful about pain. For example, there's also a study where the patients think about the movement of the shoulder. And when they thought about the movement of the shoulder started to hurt. But if we teach the patients, then they should not be fearful about pain. They can start to move again. They can start to do all kinds of physical activities despite of pain.
Yeah, so definitely some aspect of pain exposure there.
Yep, that's also from this, there are also so many treatments derived like graded motor imagery and also many other treatments that we can have pain, but we can also do all kinds of physical activities that we like, and we can live our life the way we can.
I know one of the areas of your interest is manual therapy. And I know you're going to probably do some research in that area potentially in the future as you delve into your PhD. I'm just wondering how you see the research being built out with regard to manual therapy and pain neuroscience education, because those connections have started to been discussed in the literature, but not the way we've kind of just discussed the cognitive aspect of P&A. We haven't really discussed much how manual therapy has an impact on those central mechanisms that we spoke earlier. We talk a lot about how manual therapy has an impact on peripheral mechanisms, but how does it impact those central mechanisms?
For example, just like pain neuroscience education, we can also use manual therapy. But if you use manual therapy, the focus should not be in the structure that we treat. We have also seen a shift nowadays, because manual therapy was used for example, 10 or 20 years ago. When patients when physical therapists treat patients with manual therapy, the focus was also in the structure. we treat low back pain and the focus was in the disc, we can do a manipulation, then the disc will get in, or we can do a manipulation, then we can solve this issue. But if we can use manual therapy, then we can get short-term outcomes mainly. Because we all, for example, we are also doing a paper about the manual therapy and dependency with Professor Cook. And if we use manual therapy, then we have nowhere seen that if we use manual therapy, then the patient will be dependent on the physical therapist, or the patient will be dependent on the chiropractor that is doing this kind of treatment. But we can use manual therapy as a support treatment with pain neuroscience education, so we can teach the patient that he can move again, and we can teach the patient that even if we do this kind of manipulation or mobilization or any other therapies, we can also educate the patient about pain. And there is no connection to be seen here, because if we educate the patient that he can move again, and if we do manual therapy, the focus should not be in the structure that we treat. And we should not say to the patient that if we do the mobilization or manipulation, then we can do some kind of magic tricks with them.
Right. So when we're explaining magic tricks, I like that. So when you're explaining mobilization or manipulation, as you mentioned, we should very much pull back and limit just a pure biomechanical explanation and start to explain how it impacts the nervous system.
Yep, the neurophysiological effect of the manual therapy.
Okay. Can you give me an example of that? So let's say I have a patient and I don't know, I'm just doing a really simple PA mobilization on their lumbar spine, right? To increase mobility on the lumbar spine, to increase lumbar spine extension, let's say. What I just gave you right there is a biomechanical explanation. I'm just doing that so I can increase the range of motion on the joint. How would you explain it to a patient in a way that's more in line with a pain neuroscience education approach?
Yeah, for example, if we did this manipulation, the solution is here that we didn't impact the part that we treated, but we impact the central nervous system. The central nervous system would be impacted in a way that if we treat or do a mobilization, or if the patient, for example, runs or does any kind of physical activity, the painful or the pain mechanisms that process pain will be calmed down. For example, if the physical therapist or chiropractor treats the patient, the pain mechanisms will decrease because the central nervous system or the brain produces pain. And when the brain sees that everything is okay, everything is all right, the patient can move, we can touch the structure, we can mobilize the structure, the pain will decrease because there is no danger, or there is no nociceptive mechanism that will activate pain or that will increase the pain for the patient.
Nice. So this touch in general, or manual therapy, is helping to decrease the sensitivity of your nervous system.
Yep, the sensitivity will always be decreased if we do some kind of mobilization or if we do some kind of physical activity, because if the central nervous system is sensitized, then always the patient will have pain, because if the patient has chronic or persistent pain, then the brain or the central nervous system will learn to produce pain, and this will be always increased until the nervous system will be retrained to have pain and to move despite of pain.
Yeah, I really love that, because so often when therapists first come to things like pain neuroscience education or cognitive behavioral therapy or acceptance and commitment therapy or mindfulness, one of the challenges they have is, how do I fit this in? How do I divide my time up? How do I organize a treatment session? And I tell therapists all the time, don't take out manual therapy. Yes, or maybe you may have to modify some of it, but don't take it out, and use that time with the patient as a way to not only deliver effective manual therapy, but to deliver an effective cognitive intervention. And that's one thing that we have as physical therapists that we can utilize that psychologists don't have. Psychologists can work on the cognitive and the talking aspect just like we can, but we can also do that in a way where it's laid over manual therapy or laid over exercise. And I think that's the real beauty of all these different types of interventions. But it takes therapists a little while to figure out, how do I organize this in my plan of care over the course of 8 weeks? And then how do I organize it within a single treatment session? I think what you just said is really key. use it with manual therapy, use it with exercise. And when
The one thing that physical therapists and also other medical professionals have to understand is that there is no competition. There is no competition between manual therapy, acupuncture, or also pain neuroscience education. They can all work together to get the best out of the patient. Many people see this as a competition. For example, I'm not a psychologist. I can't use education. I want to educate the patient. I will just do manual therapy. I will just exercise with the patient. That's it. But these treatments are all effective if we use them all together.
Right. They're effective when you use them all together. And I think that's the real key there. And I appreciate that. Rilind, it's been great chatting with you today about your paper. Again, I'll mention the title here. Can we just talk our patients out of pain? Should pain neuroscience education be our only tool? You can find that in the Journal of Manual and Manipulative Physical Therapy, 2021. Make sure you check that out. It's been great chatting with you. I wish you well as an early career researcher, and I'm interested to see what you produce over the next 2 to 4 years as you work through your PhD. In the meantime, let everyone know how they can reach out to you and learn more.
Yep, I'm also on Twitter at Rilind Shala PT. We have also ResearchGate, Google Scholar, and so on. I'm also on Facebook at Rilind Shala, so they can find me more, and they can look all about other papers and other projects that we are doing with the team.
Great. And of course, we'll link to this paper in the show notes. If you have any questions about how you can contact Rilind, of course, you can find all our information, which is transcribed on the webpage at the Integrative Pain Science Institute. Just go to the Integrative Pain Science Institute, scroll over to the top where it says podcast, click on podcasts, and scroll down, and you'll see Rilind's episode here. At the end of every episode, I ask you to share this out with your friends and family and colleagues who are interested in pain and pain neuroscience education. Share it on Facebook, Twitter, LinkedIn, Instagram, in a Facebook group or another group where people are talking about the effective care of chronic pain. I'm Dr. Joe Tatta, and I'll see you next week.
Thank you for listening to the Healing Pain Podcast with Dr. Joe Tatta. To subscribe to the podcast and learn more, visit integrativepainscienceinstitute.com. That's Integrative Pain Science Institute.com. Sign up to receive weekly updates, leave a review on iTunes, and share this episode with your friends.